Welcome to this webinar where we're going to talk about communications and clinical coordination. It's going to be a very interesting session because we're going to talk about things which occur commonly, particularly in hospital, and we need to be able to deal with making contact with other colleagues and doing it correctly. So first of all, I'm going to give a short presentation here and take you to the situation where in a recent review, a junior doctor at the Countess of Chester Hospital swapped 1,355 Facebook messages with Lucy Letby, and in these messages, there was clinical information conveyed on the Facebook messages. That should not have happened. It happened in 2016. Everyone knew what the rules were. You should not convey information about patients on social media. And in fact, at that time, WhatsApp was also banned as well as Facebook. Now, in 2018, I was very aware that there was a problem of communication, and I was also aware that WhatsApp was being extensively used at that time, but it was not approved by NHS England. The College of Surgeons, for whom I was regional director, was not keen on getting involved because the GMC had provided guidance, and that guidance indicated WhatsApp was not appropriate for in the clinical setting. I believed that the whole topic needed to be revisited, and my view was that the NHS, because it was unable to provide a WhatsApp equivalent, should be providing up-to-date guidance on how and when we could use WhatsApp for communicating information between medical and nursing staff. We knew that images were being communicated between clinicians, and this had been published in the BMJ blog, but I was keen for the Royal College of Surgeons to push this further. And as their regional representative, I took it up. And I contacted the director for trauma, and he suddenly told me in 2018 that after a lot of hard work behind the scenes, the National Health Service England had approved WhatsApp, but it still hadn't announced it publicly. They had a major trauma event in Nottingham in 2018, and they did use WhatsApp in the knowledge that it had been approved by NHS England, and it was found to be extremely helpful and was strongly advocated. Of course, things all changed when COVID appeared because we were in a crisis situation. We had to communicate, and we had no option but to use the best communication channels we could in the middle of the pandemic. And to be fair to Matt Hancock, who was an advocate of the use of digital within medicine, he said that WhatsApp was a key to flexible working in July 2020. And we all agreed with him, and we did use WhatsApp during the pandemic. The rules were actually relaxed during the pandemic, but they were tightened up subsequently. So what we're going to hear now is a discussion about communication and the challenges of clinical coordination. How can we better manage information flows across boundaries? And Dr. DJ Hamblin, an emergency medicine consultant, is going to tell us about how we should try and do this, how to do it well, and how to avoid the pitfalls. DJ, over to you.
So welcome everyone. My name is Dr. DJ Hamblin-Brown, as Angus said. I'm an emergency physician, also run a small digital health tech company called Careful, which is designed to overcome some of the problems which Angus has just highlighted. So I just thought I'd start with a story that I heard this morning. Interestingly enough, this was from the CEO of the Southeast Coast Ambulance Service, Simon Weldon, who went out as part of his, when he first got the job as the CEO of the ambulance service, he went out on a job to, to expose himself to what was going on. And one of the first calls he went out on was with a crew that ended up at a person's house who was a woman who was threatening to burn the house down. And they got there, and it was clear that the woman was in significant distress. And they spent I will summarize the story. He tells it much better than me, but they spent 2.5 hours at the property trying to find out what was going on with this woman. And they rang various different places, and then they were told to ring other numbers, and then they rang other numbers, and eventually got hold of some people who went, oh, yes, that's quite normal for her. She's always doing that. And what she really needs is she needs a prescription. She needs a prescription for something. And that's, in fact, the reason why she was making such fuss is that was the way she got attention from people to get things that she needed, and what she really needed was a prescription. And so they then had to phone around and find some pharmacies, and they had to find a doctor that was able to sign the prescription. Anyway, after 2.5 hours, they managed to sort it out in such a way that the pharmacy ended up with the prescription that she needed, and she was able to go there and get it. Now, obviously, the default position would have been for them to just simply escort the patient, perhaps under police escort, to the local hospital, but they didn't do that. And as a result, they managed to get what the patient needed, which was some clinical attention from the relevant people. And this really highlights a brilliant story from better told by him. It really highlights the issue of trying to bring together all of the people within a patient's care, trying to understand how it is that we can make faster decisions, better decisions when faced with complex pathways. I'll just come on to another example from my own experience. So an elderly man came into our emergency department some time ago. I remember him very well. Obviously, his name has been changed, but he was mild dementia, lived at home with his wife reasonably well, but he'd been largely bed and chair bound. He was treated in hospital for community-acquired pneumonia and then discharged, they discovered that he had a significant pressure ulcer and had been managed reasonably well during his inpatient stay. And when I saw him, he was being readmitted 2 weeks after his initial discharge because he had sepsis, which was coming from his pressure ulcer. And it was clear that in the intervening 2 weeks, his pressure ulcer had not been managed at all in the community. And that was because the district nurses and the general practitioner had not been made aware of the management plan for that, and therefore his care had been inadequate in the community, and largely because the flow of information, the plan of care, had not translated from the acute to the community setting. And this is really very common. In this case, it was pretty difficult, and I wouldn't say necessarily catastrophic, but it certainly meant that the NHS certainly suffered unnecessary costs, but more importantly, the patient and his family suffered unnecessarily from poor patient care. Now, this problem with clinical coordination is largely a sort of confluence of all sorts of different problems in one, largely because whereas we used to go to hospital and then either get better or not, nowadays we get semi-better and go home for a while and then come back to hospital. And we have very complicated patient pathways that go in and out of different settings, and people get stepped down to community care. And that the information about each of these different settings is held in different places, as we'll talk about in just a second. So the problems that the clinical problems and the organizational problems which are contributory to that are only going to go and get worse for the remaining part of the century. Now, it says, you think, well, mid-century, 2050, that's miles away. Well, actually, we're heading into 2024. It won't be long between it's 2030. So within 20 years, the entire landscape of healthcare will be significantly different. And the position of acute care within that will be much less important, or will play an important part, but most care will need to take place in the community, and the coordination of care will only become more and more important. So if I think now about the digitization of that, and I think this speaks very nicely, Angus, to your point, which is that in the center of this diagram we've got here is this idea that we use WhatsApp, we use Excel, we use text messages, we use all sorts of things to manage things in the moment. In my story about the ambulance crew, they were using the telephone. They rang various people, and they had to use the telephone because there wasn't any way of doing this in any better way. But wherever you go in healthcare, there are things that are being used to manage patient care and patient pathways in the moment, which are completely devoid from what we consider to be the definitive patient record, which is often stored in larger systems such as those ones mentioned here. And what we find is that very often, because of the difficulty in managing the present, we spend almost no time at all thinking about what's happening next and indeed who is responsible. So for instance, who is responsible for the dressing change for this patient as they come out of hospital? It's not written down, it's not managed in any sort of digital fashion. And as a result, as indicated by this thing, the amount of headache that is caused by that is substantial. And actually, I would put it to you that if you're listening to this, have you yourself or one of your relatives suffered from a problem with care coordination? I rarely come across anybody for whom the answer to that question is no. Almost everybody that I speak to says, yeah, my grandmother, my child, me personally, we had this problem about, this not happening or that not happening. And interestingly, thinking about the emphasis of recording the past and thinking about the future, of course, as patients, we care much more about the future than we do about the past. The past is gone. What we care about is how are we going to feel? Are we going to get better? Are we going to be like this forever? Who are we going to see next? Who's going to look after us when things get worse potentially? So actually, we are not recording the sort of information that we need in the service of the patient's needs. So another way of looking at this, I like this little diagram, which is been well used in the internet. It's a meme used for all sorts of things, but the indication of this is that the whole of the structure of the NHS rests on the idea that really all of the little bits are held together by WhatsApp, Excel spreadsheets, and email in particular. So what's going on here? Talking of sovereignty, I think it's really interesting to see that each of the different trusts in the NHS, and it's true in other parts of the world as well, that each of the institutions have their own sort of ownership of the data that is responsible for a patient. So you've got these huge systems in hospitals, you've got encounter management systems and appointment management systems in the community, and then depending on where you are in the world, you have a variety of patient apps which may be relevant to your diabetes, or they might be about dementia management, or they might be, if you're lucky, some sort of portal into your local hospital. But it's not a unified system whereby you as a patient can see all of these things. The good news is that there is an emphasis, certainly in the UK, on trying to change that, because as you will, I'm sure anyone who's read the paper from Darcy, the NHS Review, there are three key themes coming out of that: from hospital to community, from cure to prevention, and from analog to digital. So this, as I said earlier, the importance of community care and the centrality of community care to a patient's journey is only going to get more significant. And of course, going towards a preventive measure means that doing things on time, doing actions, being very clearly focused on who's supposed to do what in the future is really important to prevention. So if you need to prevent people from developing the consequences of type 2 diabetes, you need to make sure that you are screening people effectively, not just every 3 years, but when their HbA1c goes up a bit, you need to screen them more frequently. Well, that may be done by your GP, but what happens if you move around? And indeed, it may be that your GP doesn't have a reminder system on their system. So the question is, who is responsible for making sure that we prevent the worst outcomes from type 2 diabetes? And the answer is no one at the moment. And that's one of the reasons why it's dangerous. And of course, as Angus, you mentioned this idea that we need to get more savvy about how we use digital products. So I'm just going to have one more slide before I stop and ask questions. And that is that I think there are three things that we need to do, because we asked the question at the beginning of this presentation, how are we going to overcome these barriers? And I think my feeling is that we have sold digital systems to acute trusts, mental health trusts, community trusts, and the business model of these large EPR providers, the electronic patient record system providers, is to sell to purchasers who are interested only in the organization. So they've put, as Simon Weldon put it earlier when I was speaking to him, he said, we haven't put the patient at the center of their digital journey. We put the organization at the center of the digital journey. And so instead, what we should be doing is trying to create a layer of coordination that stitches those bits of information together, but not by simply putting them together. And I think this is an important sort of metaphorical difference. Instead of just taking one large silo of information, say in the hospital, and tacking it into another large silo of information, which is maybe the mental health trust or the GP surgery, and somehow trying to ram them into some larger silo, or as it's sometimes called, a data lake. Actually, what we need to think of digital coordination as being something which sits on top of all of that stuff and forms a layer of digital tools and digital interaction. And the second thing, which flows from that observation that most digital systems have been purchased by institutions, is that we should start getting the institutions that are responsible for population health and public health potentially to start looking at purchasing systems which will themselves be part of that layer that I mentioned. So in the UK, the ICSs and the ICBs would act as digital commissioners for this new layer. And I'll finally say that I think that those two things are clearly the most important, but for that to happen, we need improved digital literacy, particularly at board level, but also at the front line. People aren't going to be able to use new digital tools if they're commissioned badly. Or they're used badly. The commissioning is really ultimately the responsibility of the board, and the board of the health system is what I'm talking about here. But they also have to be used by the front line. And I think, Angus, one of the reasons why UK DHC exists is because we recognize the importance of having systems that work for frontline users. So those are my three parts of my wish list in order to improve clinical coordination across boundaries. And so I will, having cantered through that, I'll stop and ask for questions.
Well, I think that you have highlighted what the real problems are at the moment. It's the coordination and the integration. And to be fair to the NHS, they are trying. I know when Matt Hancock was Minister of Health, he was very committed to making the NHS more digitally orientated. He was a great fan of moving in that direction. It was unfortunate that we had COVID, but actually COVID turned things around. And COVID meant that we had no option but to start to use our digital apps in a way that we never had done so before. And even to the extent that NHS England decided to virtually scrap the regulations and let people go ahead as best they could to communicate with each other. So that was good. And then in 2021, the ambulance service distributed or were given 30,000 iPads. So people are trying to do the right thing, but there is a problem, I think, with coordination.
Yes, and interesting. So giving 30,000 iPads to your, so CCAM, the local ambulance service for my trust, use iPads. They come in, they ask us to look at the information that they've gathered. We sign the iPad digitally, and then they go and print it out on a piece of paper. It gets given to us, and then we then scan that piece of paper into the notes as an e-note. That's how. I mean, that's so. This is interesting. So I think you're absolutely right. The government is trying, but what I'm trying to get across with this last slide of mine is that this idea of the layer of collaboration is what's important. At the moment, the metaphor is, oh, well, we must integrate these things by getting this hospital to talk to this particular ambulance service. And if we can only get that to work, then we'll have a sort of spider's web of integrations where everybody's to talk to everybody else. Whereas my view is that there actually is an argument for saying, let's just leave all these systems the way they are. Let's have a layer of collaboration, which allows us to store not a lake of information, but just it's like a sort of, it's the icing that you need in order to get all of these big systems to talk together, is not by individually hooking them up, which is the sort of paradigm that people use, but to provide and commission a layer of collaboration which will allow people to communicate.
I was reading a story from a lady in New York who had her medical records stored with one particular electronic patient record company, and they were transferred to another and got totally lost in the ether. And all her medical records have vanished, and she is now bereft because they have all gone. I suspect we have a danger of that happening in this country as well, intermittently. And it's very important that we somehow manage to transfer records between providers. And that is something the providers have not been helpful with. What's your view about that, DJ?
Yes, well, of course, the business model of these larger digital EPR providers is to sell to individual institutions. And actually, it's not in their interest to help institutions communicate between each other. And that may sound cynical, but I don't think there's anyone I've come across that hasn't had the experience of finding such integration and such interoperability very difficult. So, yeah, I think the ability to transfer records from one place to another is certainly possible. I mean, there is a mass of standards out there, FHIR and HL7 and whatever. What I would say is that what normally happens is if you want your hospital record, they print it out and then you take it away in a suitcase and bring it to another hospital. And that's certainly the case between the private sector and the NHS in the UK. Well, and I'm sure it's true between private providers as well.
Yeah, that was another question I wanted to ask you. Now that the NHS is adopting private care for its NHS patients under various circumstances, how do they communicate so that the medical records go from the private care setting back to the NHS? Have you any idea how that works? Or does
well, again, I think it's largely done on paper or via email in PDFs. Maybe there are places that have got a sufficiently large amount of traffic between them that they've digitized that transfer. But interestingly, I'll just put the other thing that I think is worth emphasizing, in my view, and I'm happy to take some challenge on this, is that actually you don't need to transfer your entire medical record to a new provider in order for them to provide a service for you. You need to provide the salient information. So, for instance, when a GP refers a patient into an emergency department, they don't send the entire record, although sometimes they do send a list of encounters. What they really send is, this is the past medical history, this is their drugs, the list of drugs, and this is the presenting complaint and the history of the presenting complaint. And that's really all you need. You need a standard, bog standard clerking. And that's enough information to transfer. Now, is it possible that as an emergency doctor, I'd like to know what their serum rhubarb was 3 weeks ago? Well, maybe, in which case I have to ring up for it. But mostly you don't. You care only about what's happening now and what's likely to be salient and pertinent to today's presentation. So you might say, oh, this person has had chronic anemia. You don't need all of their blood results to know they have chronic anemia. I mean, and so I think we get het up by the idea that we need to somehow transfer lots and lots of different bits of information between providers and provide, proper interoperability so that I can see into this silo from my silo. Actually, that's not necessary. You just need the relevant bits of information to be readily available and fast.
I agree, and we actually have teams working on that in London at the moment, standardizing the medical records so that the medical records can contain the information that's necessary to refer a patient, for instance, into hospital. But it's been slow progress in getting people to use the formats that have been developed and published.
Well,
And that
if
is
I can
a
add
bit
one,
frustrating.
if I can add one observation, which is that often what happens is that these systems are, or the interfaces, or the forms, as you call them, are designed by committee or by an IT department rather than by a clinician, and oftentimes you just wish it was slightly different. And so pushing down the agency about changing systems to a lower level would also help. So the idea that a team could decide what it cares about rather than being told, well, this is the form, that everybody uses. It's the wonderful thing about paper is that it's really flexible, and it's flexible at the point of use rather than it is flexible in theory. It's flexible because you can scribble in the margin, or you can cross out a bit of a form, or you can use a blank piece of paper. I mean, paper is incredible medium, and yet we feel that somehow digital mediums are better because they're faster and they move data around a lot quicker. But actually, paper's amazing. there's nothing wrong with paper.
On a more positive note, the NHS app is actually beginning to work quite well. And you commented on the follow-up of diabetics. If you have a good general practice and you have an NHS app, then you have the potential for getting quite good diabetic care. And I know about that personally because I'm borderline, and they have been monitoring me very sensibly and very carefully, and the NHS app has come into its own. However,
yeah, and I would emphasize that it's at the moment the NHS app is in its infancy, and I think if we were to, criticize the NHS app for its clunky interface and its the difficulty of it being used and the bits that are missing stuff, but that would to me to miss the point, which is that actually if it worked really well, it would be a fantastic asset. And in fact, it's probably the only bit of the NHS infrastructure which really does, by definition, put the patient at the heart of the bit
yes.
of it. And so I totally agree that if we can get the NHS app to really work, and I think for that it needs to interface with lots and lots of different things, and that would be the answer. I think one of the risks with the NHS app is that it becomes, rather than becoming the portal into this coordination layer that I feel we need, it becomes a big government system that is managed and written by programmers that essentially are managed by Whitehall, and that would make it slow and cumbersome and not functionally very good. I think to make it into something which has got a very open API that allows other people to deliver patient information to patients, I think would be particularly good, and I suspect that is the direction of travel.
The one digital development which I became aware of in 2012 was the Patients Know Best platform. That was developed for patients and encouraged patients to get their medical records transferred to the Patient Knows Best platform. And the reason I became involved was because I did quite a lot of shoulder surgery on thalidomide patients, and they came along with their medical notes in the Patients Know Best folder, and that allowed me to review what had happened to these patients previously. They seemed to have total charge of who got access to their medical notes. I still fail to understand why the NHS has not moved more in that direction.
Well,
Why shouldn't the patient own their own information?
Because that is not how people are rewarded, and it's not how. So if you're the CIO of a trust, the chief information officer of a trust, that is not in your remit. And that's what I was saying about putting the organization in the center of this. The organizations are responsible for buying, commissioning, adopting, adapting, in everything about information systems that are available in hospitals is managed by that institution, whether, well, it might say trust actually. So it could be so it's absolutely about incentives. It's the reason why that has not been adopted is because there is no purchaser for that system in the NHS. Yeah, well, there has, I guess there is now.
I think there is communication going on between the Patients Know Best and the NHS app, and I know they are collaborating at the moment, which is really good news.
It is.
So
I have to say,
going on.
It is indicative of how what a struggle that particular company has had, is that they have been in existence for, as you said, well over 10 years, and they still haven't made much inroads. But I'm cautiously hopeful that that sort of platform that allows patients access to their own records can be not only developed for the benefit of patients, but also made available through the NHS app, because I think that will make a big difference.
As you know, I'm now retired, but I was a very active orthopedic surgeon during my clinical life. And one of the most frustrating things that I found in clinic was that the patients were not allowed to take away copies of their x-rays with them, because the x-rays were on the computer system. They weren't allowed access to the computer system. And it was only when mobile phone cameras became really good that I realized the patient's x-rays are their property. And they should be able to have their x-rays. So I used to encourage the patients to bring their mobile phones into clinic and photograph their x-rays and take them away, because I felt they deserved it. That was against the ethos of the hospital I worked in at the time, and I might well have been disciplined for it, but I felt very strongly it was an important
that is it. That's exactly right. And that's a very interesting story, because it's about sovereignty, isn't it? It's about who owns the data. And your view is, this is a picture of your ankle or shoulder, therefore it belongs to you. And the CIO and the trust will say, no, we took the picture, so it belongs to us. And that's a really interesting. I think that has shifted markedly in the last 10 years.
I think it has now. Yeah.
Maybe we should throw the discussion open, Angus. I think you and I are violently agreeing with each other too much.
I don't know whether we have any questions from people who are attending. We've got Andrea, we've got Francois. Any questions from either of them? If they would like to come on, they can ask their question. Andrea.
I would just come from a different angle, but having looked at the points that were raised, for example, the interface with public health, I mean, from curing to preventing various things. We also know that there is a prevention paradox in general terms somewhere. However, there are issues that can be worked on to create that layer, not the lake, but the layer, in order to progress some aspects of the prevention thing. I mean, the type 2 diabetes is a good example, and there are some other I think conditions. I've been looking into the epidemiological aspects of many things at the moment, or recently, and there is potential in that aspect. And also from moving, for moving from paper, which is indeed very useful, because sometimes if you're have sufficient syncretic notes of various things, you can just grab them and you'll have the picture straight in front of your eyes. However, that could be digitized. And I'm thinking now, back in my days when I was working in the Isle of Man, I used to have two screens of the laptop, working with the data on one and with some summarizing text on the other, because we were supposed to do needs assessment and prioritize things. And obviously I didn't work at the acute side of things, but I was working with risk factors and health promotion and health education things, but we had to shift those.
I think you were lucky, Andrea, to only have two screens. I have heard stories of radiologists who have 4 screens to work from.
Well, I was coming to that point. So, because
and that is
yeah,
quite challenging, isn't it? Yeah.
it's very challenging. And I think the conference, if I recall correctly, there was somebody trying to put that through, because if you're, for example, in an acute setting and you have to monitor the vitals, minimum
Yes.
5 and all sorts of other things that are going on, and that's like monitoring them every, 10 seconds could count in the various range of values there. This is where you do have to have a, I don't know, an owl head or something. I don't know, you have to turn around 180 and
Yeah.
read and process at the same time. These are challenging things, and if you're passionate about your profession, obviously you can do them. But I'm thinking also and comparing, for example, with interpreters.
Yes.
I've worked with a lot of them, and it's a simultaneous thing where you have to do, and to receive, to process, and decide at a very fast pace. And I think you do need training for that, well, or keep up with things. Public health hasn't done much in that direction. Obviously, it's all strategically lagging in various places, but I could see the analogies.
Thank you very much indeed, Andrea. Very much appreciated. And I'm going to close this webinar. DJ, we're very grateful for the time that you have put into talking to us and putting together your thoughts. I think it's really important for us to share our experiences and make other people aware of where we perceive the problems are. And they're not simple problems. And we would like, as an organisation at UKDHC, to we would like to be able to help the hospitals, the GPs, but especially out in the care sector to use the digital tools that have been developed better than they are being used at the moment. At the present time, there are some tools there, but we are not being smarter, and they're a struggle to use, and we need to get into a situation where we work smarter and more efficiently. And thank you very much for contributing to this.
You're welcome. Thanks very much, Angus.
Good night, everyone.
Thank you. Good night. See you soon.